So today is going to be a blockbuster day because this is one day where I actually record more than 2 videos in a day, and you're going to get more than 2 uploads today. I decided to go and do stroke because this is one topic that I haven't really done on my channel. So this is going to be a 4-part video. This is part 1 of the videos. So please make sure you watch all videos so that you get the best of both worlds. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at stroke. This is part 1 of 4 videos where we will discuss just the general principles of stroke. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon so that you should be receiving notifications of such videos every time I post. Grab a piece of paper, grab your pen, and let's go. So remember, when we talk about stroke, what we're simply referring to is this syndrome where there is abrupt onset of non-convulsive focal neurologic deficit that's going to be resulting from this sudden interruption of the blood supply to parts of the brain. And often this is going to be lasting longer than 24 hours. There are some people that actually use the term cerebrovascular accident, but most literature now discourage individuals from using the term CVA or cerebrovascular accident because it's very vague and can actually mean one of many presentations. Remember that stroke is actually considered as a medical emergency because it affects many vital functions, especially things like respiration, which can actually compromise the life of an individual. It is the leading cause of neurologic disability in adults, and certain complications often result in things like dysphagia, aspiration pneumonia, deep venous thrombosis, pulmonary embolism, dehydration, malnutrition, pressure decubitus ulcers, urinary tract infections, myocardial infarction, heart failure, as well as seizures. So those are some of the complications that often cause an individual to die when they are dealing with a stroke. Before we go any further, I just want to give you a background of a little bit of some anatomy, because most of the blood vessels that are going to be affected by stroke are part of a loop of blood vessels, which we call the circle of Willis. So it's also referred to as Willis's circle. You can call it as a loop of Willis, or you can call it as a cerebral artery circle, or you can even call it Willis polygon because it looks like a polygon. So this is just simply this circulatory anastomosis that supply blood to the brain and the surrounding structures. It was named after an English physician by the name of Thomas Willis. Here's a picture of the Willis's circle. I will explain these different blood vessels, what they supply, just that you can have an idea of if this certain blood vessel is blocked, these parts of the brain are the ones that are going to be affected. So remember that most of the blood that is coming into the brain is going to be pretty much coming from the carotid arteries. Remember that the common carotid artery is going to be arising from 2 possible places. It could arise from the subclavian. It could also arise directly from the arc of, or not even the subclavian, rather, that was a mistake, but rather the brachiocephalic trunk, which is eventually going to give rise to the common carotid as well as the subclavian. Then, it can arise directly from the aorta. So remember, you have these common carotids that are going to be ascending in the neck, and eventually at the angle of the mandible are going to divide into an internal carotid artery and an external carotid artery. The external carotid artery are going to be supplying the structures outside the brain, so predominantly the skull and the scalp. Then the internal carotid artery are pretty much going to be forming part of this circle of Willis. So remember that this internal carotid artery have a left side and a right side. So remember that these left and right internal carotid arteries are branches of the left and right common carotid arteries. Then in addition to this, remember that now we have certain arteries that are going to be part of this circle of Willis. We have the anterior cerebral artery, which you have a left and a right. So if you look at this diagram over there, this one here is your anterior cerebral artery. So this is the right side, this is your left cerebral artery. And then in between there, you have an anterior communicating artery between the two anterior cerebral arteries. Then part of the common carotid artery actually is going to continue as terminal branches, and one of the terminal branches is the left middle cerebral artery, which by many is actually not even considered to be part of the circle of Willis. Then it's also going to give off two right posterior communicating branches, as well as the left posterior communicating branch. And then, of course, you also have the basilar artery at the posterior aspect of the circle of Willis, which is going to be made from the fusion of the left as well as the right, or rather the left and the right vertebral arteries. So the arteries that we actually see on the circle of Willis are going to be the anterior cerebral artery, the anterior communicating artery, the internal carotid artery, the left and the right, pretty much the distal tips, or what we call the carotid terminus, the posterior cerebral artery, both the left and the right, the posterior communicating artery, both the left and the right, as well as the middle cerebral artery, which by many is not really considered as part of the circle of Willis. So where are all these arteries coming from? So remember, I already explained where the internal carotid arteries are coming from. They're usually just a branch of the common carotid artery. So they are a branch of the left and the right common carotid artery. Now remember that these internal carotid arteries, the left and the right, are going to give rise to a posterior communicating artery, which are these posterior communicating arteries that I'm depicted on the picture here, if you can actually see my cursor. So you have the right posterior communicating artery and you have the left posterior communicating arteries, which are branches of the internal carotid artery. The internal carotid artery is also going to be giving rise to these anterior and the middle cerebral arteries. So it's going to give rise to the anterior cerebral artery and also continue as the middle cerebral artery. Remember that the middle cerebral artery is not really part of the circle of Willis. So it means that this anterior cerebral artery is pretty much going to be forming the anterolateral portion of the circle of Willis, whilst the middle cerebral artery is not going to be considered as part of the circle of Willis. Then posteriorly, you're going to have the basilar artery, which is going to be formed by the fusion of the left and the right. So this is the left and this is here the right vertebral artery. So the left and the right vertebral artery is fused to form what you call the basilar artery. Then the basilar artery is the one that's going to be giving rise to the left and the right posterior cerebral artery. So here you have the right posterior cerebral artery, here you have the left posterior cerebral artery, and of course you have the communicating branches, the right posterior communicating branch and the left posterior communicating branch, which are coming from the internal carotid arteries to join together with the right and the left posterior cerebral arteries. And then remember that these same vertebral arteries are going to be branches of the subclavian artery, and you also have an anterior communicating artery which is going to be joining the two anterior cerebral arteries, and people think that it could arise either from the left side or it could arise from the right side. So remember that all these arteries that we've mentioned are going to be giving off certain branches, which we call cortical branches and central branches. The central branches are pretty much going to be supplying the interior part of the circle of Willis, more specifically what we call the interpeduncular fossa. And then the cortical branches are the ones that are going to be supplying specific areas. They have their specific names, and these ones do not directly affect the circle of Willis. Then there is some anatomical variation. So most people that actually don't have this typical anatomical arrangement that I've just explained in the previous slide, only about 1/3 of the population actually have this classical type of anatomy. In others, they actually do have some variation. One common variation is that you have the proximal part of the posterior cerebral artery is actually quite narrow. Then the branch on the same side, the posterior communicating artery, is actually quite large, such that the internal carotid is going to be supplying most of the posterior cerebrum. So you call these people as having a fetal posterior communicating cerebral artery. Then in another variation, you have the anterior communicating artery, which happens to be the larger vessel, such that the single internal carotid artery is going to be supplying the anterior cerebral arteries, both of them. So we call this as an azygous anterior cerebral artery. So you do have this variation, and sometimes if you get a stroke in these patients that have these variations, the damage may actually be much more than compared to someone who has a classic type of anatomy. So remember that the whole function of this circle of Willis is because you want to create this collateral circulation in the cerebral circulation, such that if one part of the blood vessel is actually blocked, or it's stenosed, or it's narrowed, it means that the other arteries can actually provide enough blood supply or enough blood flow to preserve the cerebral perfusion such that the brain actually doesn't die from ischemia. So this is kind of like a mechanism to which the body has actually developed to prevent ischemia from happening. However, considering that the circle of Willis is actually found in many non-human species like reptiles, birds, mammals, and that the narrowing of the arteries is often associated with old age and human lifestyle, we generally want to accept that the function that have been suggested are actually such as dampening of the pulse pressure within the brain and involvement of the forebrain sensing of water losses are some of the things that are actually implicated in the functioning of the cerebral circulation in the circle of Willis. And another thing, just before I actually carry on from this anatomy, is that you have to note that most of the aneurysms are actually going to be happening at these branching points. So at these branching points where you have these circles, that's where most of the aneurysms and most of the ruptures are actually going to be happening. So keep that in mind. So remember that stroke can actually involve the arteries of the brain either in the anterior circulation, so these are usually branches of the internal carotid artery, or the posterior circulation, which are often branches of the vertebral artery as well as the basilar arteries. The anterior circulation or the anterior cerebral artery is going to be pretty much supplying the medial portions of the frontal lobe as well as the parietal lobe and the corpus callosum, which is a tissue in between the left and the right hemisphere. The medial cerebral artery, which is by far one of the most common arteries to be affected by stroke, is going to be affecting large portions of the frontal, the parietal, the temporal lobes. And remember what these lobes are going to be having. The frontal lobe is where the seat of intelligence is. You also have pretty much the motor centers being present there. So you may get some motor symptoms. The parietal lobe is pretty much the sensory area of the body. Then the temporal lobe has to do with, of course, hearing. Then you may also have branches of the anterior and the middle cerebral arteries, which we call the lenticulostriate arteries. These are going to be supplying the basal ganglia. They're going to be supplying the anterior limb of the internal capsule. You have the vertebral and the basilar arteries, which are going to be supplying the brainstem, the cerebellum, the posterior cortex, and the medial temporal lobe. So it means that strokes that are affecting these areas have the potential to actually stop your respiratory system. So these are actually quite lethal. Then you may have the posterior cerebral arteries, which are pretty much going to be bifurcating from the basilar artery, which is, of course, a fusion of the left and the right vertebral arteries. And these are going to be supplying the medial temporal, including the hippocampus. They're going to be supplying the occipital lobe, the thalamus, the mammillary, as well as the geniculate body. So remember that the anterior and the posterior circulation actually communicate in the circle of Willis. So keep the circle of Willis in mind and the different types of blood vessels which are going to be supplying the brain, because this is going to be anatomy that's very important to understand when we talk about stroke. So remember that stroke can be classified according to duration. It can also be classified according to etiology. So according to duration, we have predominantly about 5 different things that you really need to know. So we have a transient ischemic attack, which we will discuss in a separate lecture. It should be the last video of these 4-part series. So this is where you get this focal neurologic deficit that's going to be lasting less than 24 hours, and it's often going to be confined to an area of the brain perfused by a specific artery. So remember that these neurologic symptoms or this neurologic deficit is going to resolve within 24 hours. In most of the cases, the deficit actually resolves within an hour, and we see that the symptoms will actually resolve. So if actually they persist beyond an hour, it becomes unlikely for them to completely resolve very quickly. Then you may have a reversible ischemic neurologic deficit, or RIND, where someone has this sudden onset of focal neurologic deficit that's going to be lasting more than 24 hours, but then the neurologic deficit recovers within 3 days. So we refer to that as a reversible ischemic neurologic deficit. Then you may sometimes have a prolonged or protracted reversible ischemic neurologic deficit, or what we call PRIND, where someone has this sudden onset of neurologic deficit that's lasting longer than 24 hours, but the deficit tends to resolve within 7 days. You may have a stroke in evolution where you have this focal neurologic deficit that just keeps on progressing over a couple of hours or days. It hasn't yet reached its maximum potential. And once it reaches its maximum potential, then you refer to that as a complete stroke. Because remember, with the complete strokes, you have this focal neurologic deficit that is neither going to improve or get worse over time. So it's just like a static lesion. The reason why you may see that the patient actually gets better, it's because of the phenomenon of cortical plasticity and the brain actually adapting, and this person actually adapting to the stroke, but the stroke will still be there. So these zones are often associated with either ischemic type of stroke or hemorrhagic type of stroke, which I will do in separate videos. So you have to really note that the terms transient ischemic attack, reversible ischemic neurologic deficit, as well as protracted or prolonged reversible ischemic neurological disorder are rarely used, and we just use the term stroke, whether it's an ischemic stroke or it's a hemorrhagic stroke. So what are some of the causes of ischemic and hemorrhagic stroke? Remember, by far 80 to 90% of the cases of stroke are going to be ischemic, and these are very common in developed countries. This is often attributed to lack of blood flow. So this lack of blood flow can either be blockage that's arising from an emboli, so it could be embolic, can be blockage arising from a thrombi, which could be thrombotic, or sometimes it could be in the background of hypoxia, which we refer to as hypoxic. So these are the causes of ischemic stroke. Then with the hemorrhagic stroke, these are much more common in developing countries. They are much more common, and in developed countries are not as common as ischemic stroke. So in developed countries, it's about 10 to 20%. So these ones are often attributed to poorly controlled hypertension. And what you actually have to note is that in a younger individual that actually develops a stroke, you should suspect that possibly they could have sickle cell. And remember, sickle cell can actually cause both ischemic type of stroke as well as a hemorrhagic type of stroke. So with the hemorrhagic type of stroke, it could be someone having a primary intracranial hemorrhage, or which could either be intraparenchymal or intraventricular, or it could be in the background of an extradural hematoma, a subdural hematoma, or a subarachnoid hemorrhage. I will show you pictures of this in the specific lectures of hemorrhagic stroke. So remember that stroke is by far the third most common cause of death behind coronary artery disease and cancer. It's the leading cause of disability worldwide. It's very common among Asians as well as Black Africans rather than Caucasians. And remember that the risk of stroke generally increases with age. So a quarter of the strokes actually do occur before the age of 65, and death from stroke is actually going to be about 20 to 25% of the cases. Certain risk factors can be divided into non-modifiable, so things that you can't really change. You can't really change your age. Even if you tell someone that you're young, your age genetically would still be the same thing. So increasing age, male gender, this I presume could be associated with certain behaviors that are seen with male genders, but of course now even more females are now starting to act like men. Then you may have certain races, like for example the Blacks and the Asians, and modifiable risk factors, things that you can change, can be divided according to the systems. So you may have cardiovascular risk factors, things like hypertension, which is the number one risk factor, congestive heart failure, myocardial infarction, atrial fibrillation, hyperlipidemias, rheumatic heart disease, sickle cell disease. Keep these conditions in mind, because when we come to investigation of stroke, it is these conditions that we often tend to look at. Then you may have coagulation abnormalities like factor V Leiden, protein C and protein S deficiency, thrombophilias, which are very common with ischemic strokes, coagulopathies like warfarin toxicity or liver disease. These are going to be pretty much associated with hemorrhagic strokes. You may have endocrine disorders like diabetes mellitus, insulin resistance, and other factors like HIV and AIDS, lifestyle, which could be things like obesity, cigarette smoking, acute alcohol abuse, combined oral contraceptive use, estrogen use, lack of physical activity, a high-risk diet, which is going to be high in saturated fats, in trans fats and calories, and then, of course, also psychosocial stresses such as depression. You may sometimes have inflammatory or congenital conditions like vasculitis in the term of systemic lupus erythematosus, Takayasu arteritis, homocystinuria, amyloid angiopathies, as well as mitochondrial disease and syphilis that can cause problems to the blood vessels. You may also have certain drugs that tend to raise the blood pressure like cocaine and amphetamines, which also put the patient at risk of a stroke. What are some of the clinical features? These are going to be largely dependent on the part of the circulation that is affected. Generally, they may have facial drooping, they may have one-sided arm or leg weakness, so they may either have hemiparesis and hemiplegia. So remember that the word paresis means something to do, a condition that's causing muscle weakness or muscle impairment. So some people actually refer to it as a mild type of paralysis. Then you may have a paraplegia, or rather a plegia, which is referring to paralysis. So it could be hemiplegia, where you have this paralysis affecting one side of the body. It could be paraplegia, where you have this paralysis that's affecting the legs and the lower body. You could have quadriplegia, which is also referred to as tetraplegia, which is paralysis that's below the neck affecting all four limbs, or diplegia, which is affecting both sides, but more predominantly affecting the lower limbs more than the upper limbs. Some people may have verbal defects such as slurring of the speech, difficulty in pronunciation of words, which we call dysarthria. You may have aphasia, which is inability to produce language. You may have verbal agnosia, which is pretty much inability to understand or comprehend language. They may have some visual defects like homonymous hemianopsia, which is blindness on the same side of the visual field. You may have transient monoocular blindness, that's blindness in one eye. You may sometimes have altered level of consciousness. Remember, this is much more common with the posterior circulation, those that are affecting the basilar artery, because these are the blood vessels that are going to be supplying the reticular activating system, a system that is responsible for keeping you conscious. You may have other symptoms such as ataxia, that's uncoordinated movements, imbalance. You may have vertigo, you may have headache, confusion, dizziness, sometimes even systemic or autonomic disturbances such as hypertension and fever. Severe headaches is usually going to be indicative of a subarachnoid hemorrhage, and if you get a patient where it's in the background of an impaired conscious level, or they are in a comatose state that was preceded by some headache, nausea, vomiting, then this should suggest that this patient actually has increased intracranial pressure. This usually occurs about 48 to 72 hours after a large ischemic stroke, and it can actually even happen earlier in the hemorrhagic stroke. And fatal brain herniation can actually be a feared complication that we actually want to look out for. You have to really note that neurologic deficits are usually going to be determined by the location of the stroke, which is why I labored so much to talk about the circle of Willis, and why I labored so much to talk about the blood vessels and the parts of the brain which are going to be supplied by those blood vessels. Remember that the anterior circulation strokes are going to be causing unilateral symptoms, while as the posterior circulation strokes are going to be resulting in unilateral or bilateral defects. Differential diagnosis includes a space-occupying lesion such as a neoplasm or an infectious process such as a sepsis or an encephalitis, trauma, which could be subdural or epidural hematoma, toxins like medications, certain medications, hypo or hyperglycemia, electrolyte abnormalities such as hypo and hypernatremia, migraines. Sometimes you may have seizures, especially with something that we call Todd's paralysis, where someone has a seizure and all of a sudden they have paralysis on one side of the body. We call that as Todd's paralysis. You may also have syncope, old strokes with intercurrent illnesses, Bell's palsy. All these are differential diagnoses of a patient that's presenting with a stroke. Now, what are some of the investigations that we want to order? Remember, this is an overview of the stroke, so make sure that you watch this video till the end and watch all the videos in series. Do not skip certain videos, because you may think that you know this information and then you get to the next video and you're confused because this information is dependent on the information that I taught in the previous video. So please make sure that you watch all 4 videos. Then what is the diagnostic investigation? So when I get a patient that actually comes in with a stroke, the first thing that you must order for is an urgent non-contrast head CT scan. The reason why we don't use contrast is because we are not so sure whether this is a hemorrhagic or whether this is an ischemic stroke. If we use contrast, we may actually worsen things. So generally, you get an urgent non-contrast head CT scan. An MRI would actually be better, but usually this takes some time to do as compared to the CT and even certain logistics. So remember that here, this is going to help you distinguish between hemorrhagic and ischemic stroke. This is very important because the management of hemorrhagic stroke is different from the management of ischemic stroke. Remember, in hemorrhagic stroke, you want to stop the bleeding. In ischemic stroke, you want to stop the clotting. Now imagine if you give anticoagulants to someone who's having hemorrhage already. It means that you have created a disaster. So remember that this is going to be done as soon as possible. So ideally it should be done within 48 hours and no longer than 7 days after the stroke. We can do a diffuse weighted MRI. This is best to localize the location and the size of the ischemic stroke, though we rarely use it in our setting. You may actually get an ECG if you're suspecting that this is of a cardiogenic origin, to rule out some arrhythmias such as atrial fibrillation and flutter, as well as myocardial infarctions. You may do an echo, a transesophageal echo for suspected cardiac emboli, and other investigations include a Doppler ultrasound, a CT angiography, or even a magnetic resonance angiography if you want to actually visualize these extracranial carotid arteries and actually evaluate them for stenosis. Remember that stenosis that is termed as significant is if the lumen has been obstructed to more than 70%. So here's what a CT scan looks like. This is what a normal CT scan actually looks like, and here's the anatomy that I have labeled for you there. So there you have your lateral ventricles. Here you have your third ventricle. Then here you have the fourth ventricle. This is the cerebellum over there. So actually keep this in mind, keep this anatomy in mind, because it may help you actually to be able to look at the CT scans. I do have a series on my channel that I am still doing on how to read CT scans, so please stay tuned to that series on my channel. So here is another picture of the different types of structures that I've labeled out for you that you can actually pause the video and actually have a look at and actually visualize the structures from your anatomy. This will help you, so I won't go into details much about this. So the rule of thumb is that with ischemic stroke, usually the lesions tend to be darker than the brain tissue. So we tend to term the lesions as hypodense. Whilst those that are in hemorrhagic stroke, if it's acute hemorrhage, it tends to be actually brighter than the brain tissue. So we call this as hyperdense. The only problem is if you have a chronic hemorrhage, it may actually begin to appear hypodense, and it may actually appear just like an ischemic stroke. So it's very difficult to distinguish between a chronic hemorrhage and an ischemic stroke because they may look alike. But generally in the acute phase, the ischemic stroke is going to be appearing darker than the brain tissue. The hemorrhagic stroke is going to be appearing brighter than the brain tissue. So here's a hemorrhagic type of stroke. Here's an ischemic type of stroke. So here's another ischemic type of stroke. As you can see, it's even causing dilatation of this lateral ventricle on this same side. So this person here had an ischemic stroke. Here's another ischemic stroke. So you can see it's affecting this area here. It's affecting this area here. You even have shift of the midline structures here towards the opposite side, obliteration of the lateral ventricle on the same side because of the pressure and the edema that's happening on this side of the brain. Then here's a hemorrhagic stroke. As you can see, the different hemorrhagic strokes that we can see over there at different levels. Here's another hemorrhagic stroke. This one is even happening within the ventricles. This one also is happening within the ventricles and also in the parenchyma of the brain. So here are the hemorrhagic strokes. So what other investigations would you actually want to do? Blood investigations, such as a full blood count with a differential and HIV test, serum glucose and electrolytes to rule out any electrolyte imbalance and hypoglycemia, creatinine, urea, liver function test, the lipid profile, ESR and C-reactive protein, and also get some coagulation studies if you're suspecting that this is a hemorrhagic stroke. So things like your prothrombin time, your partial thromboplastin time, your INR, your cardiac enzymes like serum troponin, depending on whether you're suspecting that this is of a cardiac origin. You also want to test for thrombotic disorders using your antiphospholipid antibodies, your protein C, protein S, your antithrombin 3, your factor 5 Leiden. So this is like a thrombophilia type of screening or screening from these thrombotic disorders. Then you may have screening also for rheumatic disorders. So get your antinuclear antibodies, your rheumatoid factor, your erythrocyte sedimentation rate. If you're suspecting sickle cell, your sickling test and your HB electrophoresis. If you're suspecting that this patient actually has some drug abuse, you can get your urine drug screening for cocaine and amphetamines. Generally, complications of stroke are going to include dysphagia, aspiration pneumonia, deep vein thrombosis, which can eventually progress to pulmonary embolism, dehydration and malnutrition, pressure or decubitus ulcers because the patients are usually bedridden, urinary tract infections because they may have a catheter in them that may stay for some time, and as well as seizures. Remember that these are the complications that do often kill the patients in the long run. Now, here's a distinguishing factor between ischemic stroke and hemorrhagic stroke before we go into the video that actually talks about the details of ischemic stroke and the details of hemorrhagic stroke. Remember, ischemic stroke is by far much more common than the hemorrhagic stroke, 80 to 90%, while hemorrhagic stroke is 10 to 20%. Ischemic stroke can either be due to embolic phenomenon, which is in the background of an atherosclerotic plaque, atrial fibrillation, rheumatic heart disease, endocarditis, while thrombotic is often due to a thrombi forming from an atherosclerosis of a blood vessel in the brain. With hemorrhagic, it could be a primary intracerebral hemorrhage, which is often attributed to hypertension or some coagulopathy. Sometimes it can be subarachnoid hemorrhage, which is due to rupture of an aneurysm or trauma. Remember that the onset with embolic stroke tends to be sudden, and it occurs when the patient is awake early in the morning. That's where you have this maximum deficit, and it's not associated with TIAs, which is the warning sign, whilst with the thrombotic type, it happens in a stepwise fashion and usually occurs when the patient is sleeping, and it presents when they are waking up. So this one is often associated with TIAs. With hemorrhagic stroke, the patient is often awake and they're physically active. They may be straining. You get those scenarios where someone goes to church and they're screaming in church and all of a sudden they fall and die. Maybe they may have ruptured an aneurysm. They may have actually developed a hemorrhagic stroke. So this one tends to progress within minutes to hours. Then common clinical features include things like hemiparesis. You may have aphasia, and you may sometimes have coma, and other features actually depend on the blood vessel that's affected. Then here you do have coma in hemorrhagic stroke, headaches, vomiting, and otherwise it's quite similar to ischemic stroke. If you have a primary intracerebral hemorrhage, you may have this sudden impairment in the level of consciousness, vomiting, headache, and progressive focal neurologic deficit, depending on the blood vessel that is affected. You may sometimes have subarachnoid hemorrhage, which is this thunderclap headache, severe headache that they often complain about, nausea, vomiting, impaired level of consciousness, and sometimes some neck stiffness. When you do a CT scan, if it's an embolic type, you may see a decreased density. You may see the brain tissues appearing darker than the affected areas appearing darker than the brain tissue. Same thing with the thrombotic. Whereas with the hemorrhagic, it tends to be hyperdense, increased density. It tends to be brighter than the brain tissue. Sometimes if you're bleeding into the subarachnoid space, you may see this hyperdensity in the sylvian sulcus. You may see it in the central, in the cerebral sulcus. You may see it in the ventricles. You may see it in the basal cisterns. For example, sometimes you may get a suprasellar cistern star. So you get the star-like appearance on the CT scan. When you do a lumbar puncture, if it's an embolic or thrombotic type of stroke, it tends to be clear. So the lumbar puncture will give you a normal result. Whereas if you do it in a hemorrhagic stroke, if it's a primary intracerebral hemorrhage, it tends to be bloody. But if it's a subarachnoid hemorrhage, most of the times it's going to be bloody. So here's our management algorithm. So remember, whenever we get our stroke patients, it's a multidisciplinary approach. We want to assess the functional disability. You want to assess their swallowing ability, because if they're not able to swallow, you have to push in an NGT. Then we assess the level of consciousness, we assess the neurological impairments, whether it's motor or sensory. We order for certain investigations, routine investigations, hematological and biochemical investigations that I talked about, a chest x-ray and an ECG, then as well as additional investigations such as an MRI. If it's 2 weeks after the event, you can do a carotid Doppler ultrasound and echocardiograph. Make sure you get a CT scan. So if you get a CT scan, this is going to help you distinguish whether this is a hemorrhagic or this is an ischemic type of stroke. But in both cases, ensure that you consult neurosurgery and you consult the neuro team. If it's a hemorrhagic stroke, you should consider doing a coagulation screen. Stop any aspirin or warfarin if they're on that and reverse the coagulation defects. Monitor the BP as well. If it's an ischemic stroke, on the other hand, it depends on the underlying cause. If it's an atrial fibrillation or a myocardial infarction, we give them anticoagulation therapy with warfarin. If it's a sinus rhythm or it's an atrial fibrillation, we should consider doing a carotid Doppler. Then, of course, if it's a sinus rhythm or this patient actually is coming in with an ischemic stroke, then we want to cover them on antiplatelet therapy. So you remember, this is going to be in the long run as a secondary type of prevention. And we also want to address any modifiable risk factors. So this is just pretty much an overview of the management that we'll talk about in detail when you talk about hemorrhagic stroke on its own, when you talk about ischemic stroke on its own. I really hope you enjoyed this video on the general principles, part 1 of 4 parts of the videos. If you did enjoy, please consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.